All right, we're live. Okay, so I want to talk a little bit about transitions in care at the end of life. That's all me. I've done this presentation before. That's why all my stuff is on there. You may want to know I'm an ordained minister. I have a master's in psychology. I have a master's in social work. I'm a licensed social worker, and I have advanced hospice and palliative care social work certification. So I've done a lot of things. I started in hospice as a social worker. And then I came here as a chaplain, then I did bereavement, volunteers, now I'm a director. So I've done every non-medical piece there is to do. So the continuum of care from life-prolonging and restorative treatments, those would be most of your home care folks, right? They're coming out of the hospital or they have a chronic illness, and so we're trying to keep them going and keep them as well as they can be. At some point, palliative care comes in there. It kind of overlaps, and so one of Sandra's roles is to consult with people with chronic illness and help to make their life as symptom-free as possible and as well-supported as possible, including advanced planning for their end of life or their decline. And then when we get to the hospice part, that's where someone has said, I wouldn't be surprised if this patient passed within the next 6 months. And the doctor has to paint that picture between Sandra and the doctor. I can go to a patient's home, and if they request, you don't have to have a doctor referral for hospice. Patient can request it themselves. I go to the home, I do a consult, I hear what their situation is, and I say, this is definitely hospice appropriate. I can make that determination. A nurse can make that determination. If they're on the line, somebody that I'm not quite sure about, like a dementia patient, is very specific line there. Heart patient, ejection fraction matters, some things matter. I don't make a call on those touchy ones, but if it's someone with stage 4 cancer with Mets, no question, they'll be eligible. So I don't often do that on my own, but once in a while I would do that on my own, and I'm directing that to Lisa, who might be in the situation where she might say, we do have hospice service to offer you. It's another level of service for I say the last chapter of your life, like from here until whenever you pass, and that doesn't have to be in 6 months. There's recertification process, and so we have a patient right now who has been on for 2 years. Dementia, bedbound, cachectic, nonverbal, dependent for all ADLs. I don't know why she's still here, but she is. You look at her, you say, definitely she'll die within 6 months. She hasn't. That's where we're at with that. And Medicare allows us to keep recerting as long as we paint that picture that still they could die in 6 months. So that's the technical part of it. For us, the part of it is looking at how can we provide support from the time, it's really from palliative care, but from the time they take the hospice election, then we're doing symptom management, quality of life, and also what is this whole dying process that's happening? What do people have to do to prepare themselves and their family? What about anticipatory grief? What about your bucket list? What about things that you need to resolve in your life? Do you want to resolve them? Can you talk about them or not? And those are all kind of the dance we do with each patient, each family member. Oftentimes we'll get in there and the family will be able to be more open with us, or the patient will be more open with us than to the family, or the family will be more open with us than to the patient because it's hard. They don't know how to talk to one another about hard things. They don't want to make each other suffer more. So often we're kind of mediators between those things. And in my experience, I've been doing hospice for over 10 years now. In my experience, sometimes we can actually have those kind of, Hallmark movie resolutions of family difficulties, the miracle. The strange son comes back and everyone loves each other again and they say goodbye and forgiveness and, lights shine down from heaven, And then sometimes that ain't the case, I never go in thinking I'm going to solve a family's lifetime dysfunction. I never go in thinking that. Once in a while it happens. Hallelujah. So that's the trajectory. And then, of course, we have Medicare allows for bereavement support for 13 months after a patient passes. It's not allows for it. It is incorporated in our benefit. We stop getting paid when the patient dies, but their bereavement services continue for 13 months. We have letters that go out. We have bereavement group. We have bereavement counseling. We also offer that to the greater community. We just had our annual bereavement, our hospice remembrance service. We do that once a year, bring people together with the staff that's here because those were the people that went through those days with them. And so it's good for them to touch back in with the staff that they had if it's possible. So we're looking at a much longer trajectory than, just the the time that they're on service. We'll talk more about length of stay and all that later too. So at the end of life, as physical and functional things decrease, interpersonal well-being and spiritual needs increase. So they can't do as much as they used to do. Now they're sitting in bed or immobilized in some way, and then all these other things come to the forefront. So if you've ever been sick and you've been stuck on your couch, like most of us have been in the past few weeks, you probably have noted, when I'm sick and I can't sleep because I've already slept more than I can, then I start to be thinking about things, and then I start to be feeling things, and things come to the surface when we stop. So that happens for a hospice patient, except that it doesn't go back to normal. You know, they have a new normal, and oftentimes many new normals as little deaths happen as their decline happens. So the psycho-spiritual needs of human beings are to have meaning and balance in their life. So now they've lost function. Meaning and balance has to be adjusted. They need connection, transcendence, beauty. So we're thinking about, like, I had one gentleman who didn't watch TV, but out his window where he sat, he had a bunch of bird feeders, and that was his television. He loved watching the birds, and I happened to be a bird watcher, so we had great conversations about something not about his dying. It's about beauty and transcendent things. And then that kind of leads into bigger picture things like, how's this going for you? And, what are your beliefs that support you in this time of challenge, this time of limit and loss of yourself, your sense of self, your identity, and also loss of your anticipated future with your family. That can create lots of conversations. The need for acknowledgement and acceptance, like Steph said, acknowledging that this is hard, and acceptance that they're the ones deciding. We have to deal with our discomfort when a patient doesn't want to do what we think would be best for them. We had a Buddhist patient in Massachusetts in my practice there who took no pain medication. He had a very aggressive form of cancer that was very painful. And the nurses struggled a lot with not being able to fix that. We have the technology, just take it. And in his tradition, that was expiating karma. And he was going to sit there. He sat in a chair at a bedside table like this for the last 2 to 3 months of his life in excruciating pain. And that was how he was doing it. And so everyone, and he couldn't be touched by women. There were a lot of things going on. So, there were a lot of things that we had to take into consideration. But our process as the ones who have to accept that this patient is going to do this their way. It's their death. They get to do it their way. Fall risk patients. I had one man say, you know what, if I fall down the stairs and crack my head open and bleed to death on my floor, that's okay with me. All right, then. That's all right. We're going to try to avoid that. But if that's what you choose to, and this was a man who lived upstairs, he was 103 years old. He still had his bedroom upstairs. That was the thing that was most important to him, is to stay upstairs. When he said, when I can no longer get up those stairs, I'll stop going up there. And so then he fell down the stairs. And I told him, I'm really worried about you falling. He didn't fall all the way down, thankfully, and he didn't crack his head open and die. But he got banged up. And then he said, okay, time to put the bed downstairs. And often what we find is, against our best preparation and good judgment, we're telling people, it would be really good if you had a commode next to you. And they're like, I'm going to the bathroom like a civilized person for as long as I can. And, we have to walk with them in that process. And it's an uncomfortable process. And we have to be sensitive not to push too hard, but also offer things that dance is difficult. Now, need for self-determination, that's that as well. And then need to maintain a sense of self and identity. This is difficult because their identity is changing. They are no longer the person they were when they were well, or the person they were when they were active, or the person they were when they were working. And it's a very challenging thing for the psyche to change its image of itself with these kinds of losses. And so that is it's a kind of a tearing process of, I thought I was that and now I'm not that anymore. Who am I? I'm nobody. I'm nothing. And then trying to get people to move from that intermediary space of nobody to, I'm a person whose life is ending. How do I want to do this? And sometimes we can have an impact on that, and sometimes we can't. All of these things start to become the most important thing, and they require a lot of tenderness, of course, and gentleness and respect and reverence, really, for the process. And also the process in ourselves as we watch someone go through this process. It's a challenging thing to put your heart on the line and be in the struggle with someone every day. And then you're attached to the person and you're watching them struggle, and then you're struggling. So there is vicarious trauma. I mean, that is a thing. compassion fatigue, vicarious trauma from doing this kind of work, and you have to be taking exquisite care of yourself. And our staff is here for you if you say, wow, that was a tough one. I mean, I've left patients' homes and pulled over and cried. I've called Stephanie and be like, oh my God, I don't know what to do right now. Like, and she's done the same with me. So even in the middle of a visit, and you're like, this one's getting to me. The men that we had that bled out from liver this year, our nurse Christine was there with him, and she's a newish nurse. And so I went over to see how things were going, and I knew the situation. I knew the people as a social worker. I'd been in there. And in 10 years of hospice, that was the worst death I ever saw. It was traumatizing to me. And there are family members there who've never done anything like this. And Christine, God bless her, our new nurse, who was phenomenal, calm presence. You know, that this is the one, the EMT came in, they had to give birth, said the EMTs were shaken. You know, I was there right as they were leaving. I'm like, thank you guys. And I visibly shaken seeing what was happening. He was vomiting blood. It was horrible thing. And she just like steady on. She stayed with him until he died. She did the pronouncement. She cleaned him up. I mean, deserves an award for that one. That was amazing hospice work. And you know, that's what we're purposefully putting ourselves in the line of this kind of thing. And so it is important to remember that for yourself and for the family. All right, so interdimensional experience across the continuum. So there's functional, physical, interpersonal, well-being, spiritual. All these things are happening at the same time with a hospice patient, and our job is to be aware of it and support it as best we can. So I'm going to give you a little case of this. So here's Mrs. Little. She's having increasing difficulty with breathing at a self-rated level of 4 on a scale of 0 to 10. So there's her physical symptom. She can't walk from her bedroom to the kitchen anymore. That's functional decline. Becoming more isolated from family and friends, interpersonal. She becomes anxious just thinking about being alone at night and not being able to catch her breath. That's the internal process of, you know, what happens if I'm alone and I can't get to my meds. Or in one patient with COPD who was continually terrified that her oxygen machine would turn off. You know, and so she was just like beside herself. Could not be alone ever because of that. And then she begins to asking God, why is this happening to me? What did I do to deserve this? So then there's the spiritual part. So all that stuff's happening at the same time. Not to say that's not happening with people with chronic illness or people with an accident or other things, but in hospice in particular, this is like the ongoing process of what's happening for patients. She wakes her daughter Goldie several times a night when she gets anxious and feels short of breath, so Goldie's becoming exhausted. So here's the caregiver side of things. Goldie can no longer work out of the home and also care for her mother, so she's going to lose her sense of self, maybe financial support as well. She misses her friends and coworkers and begins to resent her mother's demands and lashes back at her. Not uncommon for caregiver stress. That's why we have a caregiver group, support group, and books that we bring to caregivers, and we try to make sure that they're caring for themselves as well. At the same time, she feels inadequate and says, I just don't know what else to do for her. Sometimes I don't feel like I'm a very good caregiver. And then she turns to her meditation practice for strength to make it through the next day. That's how she deals with that. We often tell caregivers, when the Ellen is here, go for a walk, take a nap, go do an errand, go get a cup of coffee, do something that is unplugged from that caregiving role. It's exhausting. Anytime there's a single caregiver, I'm like a dog with a bone. I'm like, we got to do something. What are we doing for them? Can we get a volunteer in there? What can we do to make sure that they get a break? Because that the statistics show that a person who's been in a caregiving role for, I think it's 2 years or more, has a 20% increased mortality rate. 20%. That is crazy. So that is a life stressor that we can't ignore. And around here, so many people have one caregiver. People have families that are dispersed all over. They don't have money to hire people. They really have us, and that's about it. And sometimes they're elderly. They've been married for a long time. That's a whole other factor. They don't have the physical ability, and they're actively grieving while the patient is dying. They're wanting the patient to die and not wanting the patient to die at the same time. It's very complex. So this is the kind of thing that we're looking at. And when we're thinking about our non-medical kind of assessment. So Medicare requires the nursing assessment and then a comprehensive assessment, which includes how's the caregiver doing, what are the bereavement risks, how's the patient doing psychosocially, spiritually, do they have spiritual care in place, do they want that, do they even know it's available, do they understand what a chaplain would do or a spiritual care counselor would do. It's not necessarily religious. People think, oh no, I'm not religious. It's not religious. It's what strategies do you have internally to process what's happening and stay as calm and integrated as you can in the process. Yeah. And it's also providing a person there who is a person who's trained to receive that burden, walk away with some of it, and leave the patient feeling a little less burdened, or the family member. So in order to do that, we have to practice what I call the art of presence. And I called it this for a very specific reason, because it's not a science. Being present with someone is not a science. And the art of that is, first of all, being able to be present in yourself and okay in yourself, and not going in with an agenda or leftover stuff from your day or your family or your whatever, the last patient even. Sometimes I like being on the road because I drive from one patient to another. I have very specific music I listen to. I don't use my phone. I prepare myself for the next person. I'm a praying person. I pray, okay, help me to be what they need me to be there for them. Is there anything I need to anticipate? I might have one or two things like I'd like to talk to them about funeral if it comes up, if it works out, or DNR if it works out. Don't have to have a DNR to be on hospice, by the way, just so you know that. So being versus doing, it becomes more and more important. The folks in our interdisciplinary hospice team laugh at me because I have a whole list of words for the social work and spiritual care folks to use that describe being, like provided empathic presence or pastoral presence, empathic listening, emotional support, life review, rapport building, all things that are soft in terms of, they're not soft clinical skills, they're actually social work and chaplain clinical skills, but they're soft skills compared to, medication or ordering a DME or something that's very concrete. So those are the kinds of things that we want to just try to be with the patient. And then, we all have things that we have to report on. I try to give CMS only 15 to 20% of my time. I refuse to give them more of my time and energy than that, because they want me to report that I'm doing what's right. When I'm doing what's right, that's the other 80% of what I'm doing. So what they need is only worth 20% of my attention. I make sure it's succinct. I make sure it has everything they need so they can read it. We passed with flying colors our last audit. I anticipate we will again. I don't want to give them more than they're due. They're paying us. We have to report to them. The rest of my attention is on the patient, the caregiver, and the family dynamic, and our team. How's our team doing with all this? We have some very complex patients, and that can be very stressful. Comfortable to be sitting with a brand new patient who you know nothing about, and who maybe is not happy to see you and doesn't want to hear what you have to say, and you have to find a way to get into their good graces and into their heart enough so they can allow you to tell them what you need to tell them. Sandra and I have been talking about the unfortunate instances where we've been in situations where we're the first person to see someone and to tell someone that they're dying. Anyone with a chronic illness should have that information from their doctor upon diagnosis. This is likely how this is going to go. You're here on the trajectory of that. Now this year you're here, now you're here. Well, I know I've had patients that I went to a hospital, saw a patient she had COPD, but she also had a tumor that was impinging on her trachea. First time I met her, I walk into the hospital, I'm hearing the story, I'm like, oh no, this is not good. And in my mind, I'm saying, horrible death if that happens, that her breathing gets cut off, horrible. Second, I'm thinking this woman probably has a couple weeks on the outside. They wanted to transfer her to another hospital and seek other opinions, and the hospitalists did not want to tell her. They give her a prognosis, and I'm a chaplain, people. And I'm there like, and I said, I'm sorry to have to tell you this the first time I meet you, which is what I always say. I'm sorry to have to tell you this. But in my experience, this is what we're looking at here. The family's jaw dropped to the ground. The patient, thankfully, was not, awake for that conversation. I was like, this is not good. You asked for a hospice consult. What I'm telling you is, we're very close. This is not months. This is not months away. This is weeks on the outside. So then I ran to the hallway and grabbed the nearest hospitalist by the lapel and said, "What do you think?" And I said, "I'm thinking a couple of weeks." He's like, "Yeah, me too." I'm like, "Well, get in there and tell them that, because you're the one that can. That's who they want to hear that from." And so he did. He did. We got her home the next day, and I went to do the admission with a nurse. And at that point, her symptoms were that she was imminent. I mean, imminent, like I thought she might not last the night. So now I have to tell them, instead of a few weeks, I have to say, from what I'm seeing right now, I would be doing a disservice if I did not tell you that she could pass this evening. You know, she was having apnea. She was not getting up anymore. She wasn't even drinking. I mean, it was looking really bad. And she had a little bit of modeling. I'm like, and when I said that, one of the daughters who I just met at the home, she wasn't at the hospital, she literally fell off her chair on the floor crying because it was so startling. That is not the kind of care I want to do in hospice ever. Emergency hospice care is not good hospice care. It's better than nothing, but only barely better than nothing. Of course, I felt horrible, but I couldn't leave there not telling them what was happening. So I did that. And then I sat with them for a long time. I let them ask their questions. It gave them time to gather. It gave them time to, they got everybody, the whole family came. They had a house full of food and people. The patient was comfortable. The nurse was going to come back the next morning. She died really early the next morning. So thankfully, I got to be in there enough to prepare them so that it wasn't a complete trauma. And I think that probably takes, a quarter of the trauma off that experience for them. But imagine if I hadn't and someone found her dead and then they panicked and then maybe called 911 and, the kinds of things that can ensue from that kind of panic. So it's very vulnerable. It's very vulnerable to be sitting with people and have to, on the fly, be the one to take the deep breath and say the really hard thing. And not have anything. There's nothing I can do to fix this, except be present with them. That's all I got. Our heart and our hands and our experience. That's all we got. So I know that you all probably had similar vulnerable, awkward experiences with patients, and in trauma situations or in death situations. Those are the kinds of things that I think create the heart of hospice in people, is to say we are all vulnerable, and in this situation, our humility in the face of that vulnerability is the thing that we have to offer people. I'm not going to take over and save the day. I'm just going to be there as a safety net and use my own internal processes and a whole lot of prayer to help myself and them get through that process. Compassion and gentleness, those are the natural responses to suffering. If we know there's nothing we can do immediately to fix something. Like, I love morphine, not personally, but I love what morphine does for patients. When someone is struggling breathing and the family or the nurse gives them some morphine out of it, even if it's, a couple milligrams, and their breathing relaxes and their anxiety relaxes and then everybody relaxes, and now we're looking at something more peaceful, that decreases suffering hugely. So for that reason, the medicine is so important. And then the rest of it really is up to us. Can we be calm? Can we not try to take over because of our own angst at not being able to do anything, have to rush in and do something? Can we be present and supportive of people as they yell at us, as they cry, as they grab a hold of the patient, whatever their expression is? I give people a free pass in those situations. Like, whatever you do, I'm good with that. Whatever comes out of you in that situation, that's just what's happening. So the compassionate demeanor, or it's not about us. So that's a very fine line, because the family, we are their lifeline. We are probably the most important thing in those moments, for them to look at us and say, someone's here who can tell me what to do. And it is a lifeline. At the same time, it's not about us. It's not about, if our motivation is to be the one who comes in and, the Florence Nightingale thing, whether we're a nurse or not, that is in getting in the middle of their process. So we have to be like, it's not about me, it's about them. And as a human being and a clinician, I am involved, and I want to provide those supports. But I also want them to have the best experience of that death they can. So better to teach them how to do those things or model that for them rather than to do it for them. Because if they do it themselves, their grieving process is going to be better if they have that experience themselves. I had this one family with a gentleman with a lung disease that he was just having very labored breathing. Now, he wasn't conscious. He had enough medication on board. He wasn't conscious, but it was still very hard to watch. He had two 20-something-year-old daughters. So they were young. One of them was there alone. They called. We didn't have a nurse to go out. I went out. I knew the situation. The moment I walked in the door, she started yelling at me. You people said you would be here, and I knew it was, and I just took it. I let her empty. And then I said, this is really hard. This is a really hard day. And then she started crying, and so I let her empty. And then I said, let's talk about what the nurse said you could do. When's the last time you did it? Do you remember how to do it? Yes. The nurse told me that you could do that again in this amount of time. Shall we do that? So she crushed the Ativan, she got the morphine, she gave him another dose, he calmed a little bit. We sat on the couch, waiting for the wife to get back, because no 20-something should be there alone doing that. And then she told me the story about how she was hoping he would make it to her wedding, all the sadness of, this is what's going to happen. By the end of the visit, she was apologizing for yelling at me. Don't need to apologize. This is about you and your family, and this is really, really hard. It's really hard to lose your dad in your early 20s. Those kinds of things. Helping her to see that she can be accepting of herself, even though she's acting in ways that she wish she hadn't, or even though she's struggling with what do I do, or why is my mom not here, or why doesn't he just die so I don't have to suffer this anymore. That's our role, is to be that safety net. There's going to be strong emotions, sometimes chaos. We have a couple of patients right now, their family situation is completely chaotic. Sometimes it's going to be that way. Fear, grief, and then compassionate touch. I always, like Stephanie was saying about crawling up in bed with someone. I know she's not doing that with every patient. I would never crawl up in bed with somebody, but, if I had a relationship with my grandma, I would. But I will often, test people out. Some people like to be touched, some people don't. So I generally will put my hand on their arm just to see if that feels good to them, or I'll hold their hand or something like that. And then sometimes if I get to know someone, I can tell they're more of a touchy person, and then I'll make sure there's some contact. We're very sterile in our culture about contact, and I think it's part of nursing. The therapeutic touch is something they teach in nursing. Everything that we're doing, even if it's handing them a tissue, can be an experience of touch where we're offering them something. I've seen Stephanie, especially with a dementia patient, she'll rub their head, if they're disturbed at all or something like that. And some of our Healing Matters folks will do massage or Reiki or foot reflexology or something. Touch is super important at the beginning and the end of life. I think all through life, but especially in those times. So that's something that's kind of personal to you as a clinician, and also to the person that you're working with. There's my quote. We already did that. So some things to remember, and I think this is part of the internal process that we need to go through as people working in hospice and in healthcare, reflecting on your internal motives. And this is one of the harder things to do, to say, am I offering presence, or is this just my personality that I'm imposing on everyone? So I have a particular personality, as we all do. And if you saw me on a Saturday night with my friends, I would be behaving very differently than when I'm sitting next to someone at their bedside. So my thought is, I come to be a presence, and then I use all the parts of my personality depending on what the patient needs. So in social work, we call that the use of self. So I can be witty, and so if it seems like a little funniness will help, bring a little levity to the situation. I do that dance to see if that's going to work, and then or I might just be quiet, or I might talk about the Red Sox because I know they like that. I had one guy who I found out that he drives a motorcycle, and then I talked about my motorcycle, and we were like buds. And then I'm like, when the spring comes, I'm coming over here on my motorcycle, Roddy. And he's like, good. And so I showed him pictures. And he's like, now you make sure. He's teaching me about motorcycles and stuff. And that was the only way to connect with him, and it got me in. And then I could do a lot of other things for him and his wife. And I didn't actually, he died before I could go, but I did go over on my motorcycle and visit his wife for a bereavement visit, and she was thrilled about that. So that's something to think about, like when it's not about us, but we have a lot to offer, right? Each of us have a lot to offer with our own personality. Compassion and competence balance. We have to do our job. We have to be compassionate. We have to have boundaries. We have to have some boundaries, right? And being genuine is the very healing thing, to be genuine. So when Steph cries with a patient or family member, that's her genuine expression of how she feels. I have had a couple of times where I've gotten teary with people, just because you're in the presence of so much pain, your heart just can't, it just comes out your eyes. That's how it happens. Your heart and compassion versus habits and agenda and comfort zone. Like we all have our comfort zone, and that's that awkwardness. Sometimes we're way outside our comfort zone. Like, I really have no idea what to do now or say. I'm going to stand here until something arises that I know what to do with. Empathy versus sympathy or emotionality. Empathy is to feel with someone. Sympathy is to feel for them. So sympathy is a little bit of an authority thing, like, oh, I feel sorry for this person, versus I feel with them about what's going on here. I'm in here feeling with them. And that's why it's harder on our heart when we're empathic rather than sympathetic, because we're feeling it too. Personal information for patient comfort and rapport building versus friendliness, niceties, or need to be liked. I like to tell a story on this one about, I went to a patient's home and he offered me some coffee. Very intelligent guy. My first visit, sitting at the kitchen table, he offered me coffee. Well, I don't do well on coffee. I've had one tea today, and you can see how fast I talk. I don't need more caffeine. So I said, oh, no, thank you. And then we sat down at the table, we're chatting, and then, I don't know, 10 minutes in, he's like, and you won't even take a cup of coffee for me in my own home. I was like, ooh. So I said, Bob, this was Bob, so a couple of years ago. I said, Bob, I really don't do well on caffeine. I said, I really don't drink much coffee, and when I do, it's decaf. And I already had tea this morning, so if I drank a cup of coffee with you, it wouldn't be good. It wouldn't be pretty. I said, but you know what? Next time I come, I'll have a cup of tea with you. Is that all right? And so then he relaxed. This is their home. They want to be hosts, even though they're the patient. And so then he agreed to that. So the next time, first thing, of course, I had to have my tea. And that's not because I want a cup of tea. That's because he needs to give me a cup of tea. I'm going to take a cup of tea. In my former hospice, you can't take anything from patients. It's in the city. I'm like, yeah. An elderly man whose wife has dementia and his pride is his garden wants to give me tomatoes. I'm taking the damn tomatoes. I am not saying I'm sorry, I can't take that from you. So I would take them and bring them back to the office and share them with everybody. But, obviously I'm not going to take money or any possession that is,
fur coats
or diamonds or anything. But if someone wants to do a gesture that is their way of giving back and feeling like the host or hostess, that's fine with me. There are some people's homes, I'm sure you've seen, that I would not eat or drink anything in that home. So I will have to say a little fib and ask for forgiveness later that I'm sorry. Oh, I just ate, thank you, or I just had a cup of tea, thank you, whatever. So those are interesting situations in the home. It's a little different. And then respect and advocate and acceptance versus having ownership and directiveness and agenda. That's that dance also of knowing what might make things go better, but then letting them decide which way they're going to go. So for us as professionals, awareness about compassion fatigue. A couple of weeks ago, we had 8 patients die in less than 2 weeks. That's a lot for us. We had 72 patients die last year. There is such a thing as compounded grief. Even if you're having grief over a little bit of grief over a lot of people, is compounded grief. 8 in 2 weeks, and I think Annie pronounced half of them. So 4 pronouncements in 2 weeks, that takes a toll. You have to understand that, and even nurses, I know you are superhuman, but even nurses, I'm looking at you, Sandra. Look at, she's like, I'm so strong. No.
I'm reading my gosh. No. Help me out, Mary Frances. I'm looking at your slide.
And what's happening? You're like, okay.
I'm just sitting here listening and agreeing with you.
Okay.
Fully.
All right. Well, I guess why I say that is because in my history with nurses, I find nurses to be incredibly stoic and strong, and they're always like, oh no, this is just what we do. It's just what we do. And what I say as a chaplain and social worker is, I know it's just what you do. That doesn't mean it doesn't affect you. And it doesn't mean you're not feeling it. And it doesn't mean that that's a problem if you feel it. So being aware that you're going to feel stuff, and even as strong people, that's why I was calling out, because you're a strong person, and even as strong people, we are going to be affected. And even if it's not our own personal family. When I started here, my second year here, there was another week with 7 deaths, and then I had a personal death in my family. And I'm like, oh, I got this. I'm a chaplain, for God's sake. I got this. I was wiped out. And I also, it was my mom's youngest brother that died. He was about my age. died suddenly. He was married to my one of my best friends from college, and our kids grew up together. I had to fly out to where he died and do a service for her family. Then I did a service for my family. I was just wasted. And I had to call a friend and say, when I get home from this funeral, I need you to be there, and I need you to like take care of me for the next 48 hours with like, lots of TLC, no expectations for me to do anything but lie on the couch and cry and sleep, And they did that, but I'm acutely aware of the impact it has on us, and how even just a 5-minute conversation to talk with someone about how that pronouncement was really hard, or that patient's having a lot of symptoms that are really hard. We just have to take care of each other. And, that it happens to all of us. Compassion fatigue happens to everybody. And then what are the things that you do to help you take care of yourself in those situations? And, part of what we do here, we have bereavement cards so that people can sign and send a note to the people. That's part of our process to say, hey, I'm thinking of you and we didn't forget you. Also remembering that when we leave at the end of a hospice episode, that house is empty. There's no more LNA coming. There's no more nurse coming. There's no more volunteer coming. There's usually a bereavement visit or the offer of one, but that could be a person who is a caregiver with all these people around, and then there's nothing. I don't really like that part of the hospice program because it goes off to like. But what we try to do is have at least someone from our team go to the funeral if we can, to be of support. We have a bereavement call. We have sometimes nurses will go by and do a bereavement visit depending on the situation. So those are all parts of what we do to try to offer a little bit of a bridge out of that. So that's the same thing I was just talking about. Yeah, so that's it for that one. So I'm going to shut off the video now, and we'll take another little break. We're doing all right, and then I have 2 more little sections I want to go over before we finish. All right, so let's take a quick break.